that's okay with you.
Okay, let me go to, excuse me for doing it this way, but I'm going to, having to go way back up. Let me do it this way. Okay, so we're at the beginning. And my name is Andrew Campbell. I'm an MD. I'm an immunologist and a toxicologist. I'm the editor-in-chief for a couple of peer-reviewed journals, and I'm on the editorial board of about 5 others. And I want to tell you up front that I am the medical advisor. I don't get paid for it, but because of my publication, my list of publications, almost 100, I was willing to help them out. So let's get started with the first slide. And let me let you.
In 106 seconds, a generation that spends 90% of its life indoors. It all started the day we left nature behind. We filled our homes with lovely things and all the stuff we wanted. Our homes became places you would never want to leave. Artificial light replaced daylight, and we built our houses so that nothing could escape. We cooked and showered, breathed and played, slept and sweated. But we had closed ourselves in to a point where nothing could get out. So when the air turned bad inside, we tried fixing it with chemicals. And we put in little artificial suns everywhere to make the darkness bearable. That's when things started to happen. Hard to notice in the beginning. Some needed help to sleep, to breathe, to not itch. Many of us even started to feel sad. So we turned on happy lamps to make the sadness go away. Then, scientists discovered that the air inside our homes is up to 5 times more polluted than the air outside. And that the lack of daylight can affect children's learning and increase blood pressure. It turns out that kids' rooms often have the highest concentration of toxins in the house. In fact, millions of homes are unhealthy to live in. They discovered that living in damp and moldy homes increases the risk of asthma by 40%. And I learned that millions of people like me suffer from asthma and allergies caused by a bad indoor environment. And so, here we are. How the story ends is up to you, because it's not written yet. If you care about the indoor generation, do something. Begin to think and live differently. Let light and fresh air into your life again. Even small changes can make a huge difference for coming generations. Learn how at theindoorgeneration.com.
So the key to solving medical problems, basically, that are caused by toxins is, number one, detect the cause, and then remove the cause. Thirdly, repair the damage. It's pretty basic. It's what the car mechanic does. So just some basic things here. In microbiology, there are 4 pathogens: bacteria, viruses, pathogenic fungi, and parasites. So when we have antibodies to these, it means that sometime in the past we were exposed or we were infected. It's different for toxins because these 4 pathogens are living organisms. They have cell walls, membranes, etc. Antibodies to these indicate past exposure. Toxins are not alive, don't have cells like mercury or pesticides or mycotoxins. They're groups of molecules. So antibodies to toxins indicate either a current immune reaction and or colonization. So once the toxins are gone from the body, the antibody reaction fades away and you don't have any more antibodies to the toxin. So we know that inflammation can cause so many disorders, including over here, autoimmune disease, well, arthritis too, and some neurological diseases are autoimmune. So let me just give you these little tidbits. Spores of toxigenic fungi contain mycotoxins, and these are going to get into the lungs, move to other sites, and have old effects. Now, why do I say this? Because as you can see, this is not new knowledge. This is older than 40 years. So the next one is trichotistine microtoxins are very toxic. And as you can see, it affects the immune system. This is from 1983, almost, well, it's getting on in years. But the point here is to show you how long these things have been known. 2 important points about mycotoxins. One mold that produces mycotoxins usually produces a whole bunch of different ones rather than just one. And if a mold is known to produce mycotoxins, if that mold is present in a home or building or workplace, then the mycotoxin it produces is also present as well. Size matters, okay? So our hair is about 100 microns thick. Fungal spores average about 2 to 3 microns. So that's why they can get into the deepest recesses of your sinuses and of your lungs. And then mycotoxins are 0.1 microns, really small. By the way, 0.1, we're talking virus size, okay? And you can't see them under a light microscope. You need a electron microscope to see them when they're that small. And of course, they can go through anything. At that point, they can get into your, absorbed go right through the skin. So how do mycotoxins get into us, and in particular the lungs? There's, or the brain. In the lungs, they're transported across the alveolar cell membrane, and that way get into the systemic circulation, and then they get everywhere, and they go all over the body. So, and they cause a lot of ROSs, reactive oxygen species, which is inflammatory in of itself. They release pro-inflammatory cytokines, injury to nuclear DNA, et cetera. So if you want to look at, morphological pulmonary changes, emphysema, asthma in children, and lesions that are either, or it could be both, granulomatous and fibrotic lesions. So what do these people have? Shortness of breath, chronic cough. It could be mild cough, but it's still there, and trouble breathing, tightness of the chest, etc. Now the brain, and it's right up the olfactory neurons, since that's, your first cranial nerve, and these mycotoxins attach to the nasal mucosa and are transported up the olfactory nerve through the right through the cribriform plate. And that way they enter the hypothalamus and pituitary axis. And just to mention something, Dr. Ponikow, chairman of the Department of ENT Surgery at the Mayo, did a study on patients he had that had chronic sinusitis, the bread and butter of ENT surgeons. So what these people usually come and see the doctor. They've got chronic sinusitis. They get an antibiotic and a decongestant. And 2 months later, they're back again with the same problem. So he took 210 patients, took them to the OR, dug up into their sinuses, pulled out whatever he could, and sent it to the laboratory. 210 patients, and asked the lab, what is the most common cause? What are you finding? 96%, it was mold. So what happens in the sinuses, mold spores land on the sinuses and they cause inflammation. The tissues, which is basically mucus tissues, start producing even more mucus. And on top of that mucus comes and lives bacteria. So by hitting on by doing the bacterial route, giving them antibiotics, you're getting rid of the first layer, but you never truly get rid of the bottom layer, which is the molds that produce the mycotoxins. Well, actually the mold spores. So the first place that mycotoxins go to is the brain, the CNS, central nervous tissue. And what mycotoxin antibodies do is they bind to human tissue, including neural tissue, such as myelin. They trigger demyelination. And if we all remember way back from medical school, myelin in the brain is made by oligodendrocytes. Myelin in the peripheral nervous system is made by Schwann cells. So if you have a good laboratory, I use Cyrex, and they have, myelin oligodendrocyte antibodies. So now you know it's in the brain, et cetera. And that's the way you can tell if something is in the brain, the demyelination is in the brain, the peripheral system, or both. And that occurs a lot. Now here's a mycotoxin. This mycotoxin is gliotoxin. It's known to cause demyelination, leading to multiple sclerosis. Rutgers published a study, and just so that you know, two important points is that there's 6 pages of references at the end. And second is that I base all my diagnosis and treatment on medical and scientific evidence. If it's on the internet and it's somebody's opinion, everybody can have an opinion. But if they say, do this test, I'm going to say, well, can you back it up with evidence that's scientific or medical? So anyway, Rutgers says in the 210 study that, and you can read this, that they propose that fungal toxins are an underlying cause of MS. So that's a pretty significant statement from that medical school. How about ALS, amyotrophic lateral sclerosis? It's the most common form of motor neuron disease. This is from the Journal of that you can look it up right there, but it's also in the list of references. It's a progressive and fatal disease. 90% are sporadic, and 5 to 10% are familiar. And exposure to fungal neurotoxins increase the glutamate production. And so what they're saying here, that these mycotoxins could be a potential cause for ALS. Now I can tell you that I've treated about 14 plus thousand patients over the last 30 years for mycotoxins. And I've seen a number of ALS patients, MS patients, et cetera. So, and helped them and got them, especially MS patients, get them back to normal. And by the way, again, this is all medical and scientific evidence. I'm not giving you my opinion. Effects on the neuropsychiatric systems. This is from publication from Tufts University by Dr. Theo Harides. And he says mycotoxin exposure is linked to autism spectrum disorder. Okay. And so when he says this, they're followed up a study of 172 children with autism and 61 controls. This 172 autistic children had antibodies to mycotoxins. Okay, so this is a good evidence for how much mycotoxins affect the brain and how much mycotoxins are affected by how they affect the brain and nervous system. So mycotoxins are very potent protein synthesis inhibitors. They inhibit synthesis RNA, DNA. They form DNA adducts and protein adducts, cause oxidative stress, and they destroy mitochondria, and so results in cell apoptosis. Let's look at mast cell activation, which has recently been discussed quite a bit in the medical literature. IgE and we know that mast cells with the usual IgE stimulation produce histamine, heparin, and various other things, okay? And that's fine, it's what it's supposed to do. And mast cells are located on the surface of the body at the entrance to the brain. A lot of it is found in lungs and GI tissue. So IgE antibodies to mycotoxins, in addition to releasing histamine, heparin, and protease, they will cause a release of pro-inflammatory cytokine IL-6. And as many of you know, or may not know, that these cytokines will then signal the immune system to start inflammation. So cytokines are like, they regulate the immune response, the inflammation, et cetera, and have a very important role in the development of autoimmune diseases. So, and IL-6 is released by mast cells when they get stimulated by IgE antibodies to mycotoxins. I can tell you that we just completed a study. I completed a study with two other co-authors, the three of us, on mast cell activation syndrome. This is out of Washington University in St. Louis, Department of Gastroenterology. So we're doing that with that study. And there's a couple of others cooking as well. Which mycotoxins cause this? Well, here there are 9 of them. There's about a dozen mycotoxins that cause diseases in humans, that affect humans adversely. And these are the ones that cause the release of IL-6. So antibodies to mycotoxins can form adducts, and these adducts can bind to human tissues and trigger autoimmunity, anything from rheumatoid arthritis, psoriasis, MS, etc. So if you remember, treat the cause, not the effect. So in other words, you find the cause, remove the cause, repair the damage, and what happens to the autoimmunity, autoimmune thyroiditis, goes away, fades away, doesn't go away, fades away. So here's a guy. He'd been suffering for about 12 years. You can see the skin and understand that he's got psoriasis, and up here you can see that he's got rheumatoid arthritis as well. He'd been on he'd tried everything, gone to a number of doctors, internists, rheumatologists, dermatologists, etc. He'd gone to some people who don't write prescription, like nutritionists and naturopathic doctors, etc. And he tried everything. So this is what his chest looked like. And again, you can see the finger here. And then we got him away from the mold, which was producing the mycotoxins. He moved, started treatment. And here he is 2 months later. He's improved. And then at 6 months, he's much improved. So you can see by removing the cause, what you could do. Here's the lady. She's the mother of a well-known doctor. And if any of you have gone to A4M and many of the other conferences, you've heard him speak. I'm not going to tell you who he is, but this is his mom. And he sends me this photograph and said, "Can you help my mom?" So yes, we did antibodies to mycotoxins. It lit up. I told her, we had long discussions about her having to move because her home was built in the 50s and had all kinds of leaks and everything else. So she moved, and I started treating her long distance. And 6 months later, she sent me this picture, the before and after. I've never met the lady. This was all done over phone and Zoom, but that's pretty impressive. Now, here's a young gal, and she tells her own story. If you read below, she says, "I look like an addict or something." Okay. And this is before she knew that she had anything with molds. She thought she had Lyme's, had gone to a Lyme doctor and had a test, and we're going to talk about that in a minute. And then here she is after treatment for mycotoxins. There's a big difference. And here's a picture of her. You can see she looked 6 months pregnant before she started treatment. And then during treatments, starting 3 months later, she doesn't have that kind of a bloating problem. Obviously, what we know is that mycotoxins cause intestinal permeability, and then you have the bloating, the SIBO, the IBS, and all these things. So again, you don't treat what it's caused, you treat what's made it, the source. Okay, so let me give you an example of 4 or 5 mycotoxins. This one, ochratoxin, significantly, let me go back here for a second to this gal, because this is important. There's a cross-reactivity with Lyme antibodies and mycotoxin antibodies. So a lot of people have positive tests for Lyme, but what they really have is mycotoxins because of the cross-reaction. I can also tell you that if you use a laboratory that reports tests as IFA, okay, that's immunofluorescent assay. That was an assay that was great 35 years ago, but since then things have progressed. That assay is about 65% accurate, which means 1 in every 3 patients will have Lyme, but it'll show up as negative, or not have Lyme, but it'll show up as positive, okay? So the only lab that I know of that has a patented test for Lyme disease, and it gives you the antibodies, and it's totally complete and it's cheaper than most of the others, is the Lyme test by Immunosciences Laboratories in Los Angeles. That's who I've used for many, many years now. Okay, so let's get here. So what does ochratoxin, for example, do? Significantly increases interleukin-6, suppress N-acetylcysteine. You get an increased susceptibility to rheumatoid arthritis, and it causes inflammation of the nasal mucosa. Here's Alternaria Toxin, increases IL-6 secretion, induces damage to DNA. T2 toxin, and by the way, T2 toxin has been weaponized. It's been used by military armies since after the Vietnam War. It increases IL-6 in the serum. It increases tumor necrosis factor alpha. So again, a lot of inflammation. Satratoxin, it increases and potentiates the production of IL-6, and it magnifies the innate inflammatory response. You remember the slide I showed you of inflammation in the center and all these circles around it? Well, this is where you can relate that to. Here's the last one, deoxynivalenol, also mainly known as Don, like the previous president. What does it do? Affects bronchial cells directly, significantly increases IL-6 production from anywhere from 3 to 24 hours, and also is known to really have an effect on the intestinal on the intestinal barrier. It just causes a lot of permeability. So there's a lot of popular tests out there, like, so I'm going to bring that whole area up right now. You have mycotoxins in many foods, okay? Coffee, beer, etc. And the WHO knows this, FDA knows this, EFSA, the European Food Safety Authority, knows this, etc. And they set limits to how much mycotoxins are in foods, okay? And that is known as the TDI, tolerable daily intake. And it's very small amounts, parts per billion. Now, I asked a mathematician, a PhD guy, explain to me 1 part per billion, because I'm a visual, I need to be able to see something like that. He says, take 100 football fields, cover them with golf balls, and remove 1 golf ball. He says, that's 1 part per billion. And usually the FDA, EFSA, and the World Health Organization, and the United Nations Food and Agriculture Organization all have it at under 5 parts per billion. So whenever you eat these foods, naturally what you're going to do is your body's going to excrete them. It's going to get rid of them, mostly in urine. So this urine testing is not accurate and helpful because, for example, this year in July, Frey did a study, showed that 1 in 4 mycotoxins were found in pasteurized and unpasteurized milk from cows. So the milk you buy at the supermarket, 91% has at least 1 mycotoxins, and 30 have 2 to 4. However, all these, again, were below tolerable daily intake, and they're excreted in the urine, and that's what they found in this study. Now, Dr. Vrzdani, and for those of you who may know him, he is the director of Immunosciences Laboratories, and he says there's 3 questions everybody should ask. What is the source of the mycotoxins detected in urine? Why is the detection of mycotoxins in the urine not an indication of autoimmune and neuroimmune diseases? And he gives the answer. This is because most of the mycotoxins originate from food, and that's what you're getting rid of. So doesn't tell you what the body burden is of the mycotoxins, and you can't use it as a biomarker for exposure to mycotoxins from indoor water damaged buildings. Here's a common I get about 5 emails a day from patients who don't know me. I mean, there are people out there. And they're prescribed, these are popular things on the internet. There's even some people who advocate this binder for this mycotoxin, that binder for this other mycotoxin. And the result is they don't really work. They don't work at all. So this is one person asking me. Here's the study on binders, animal studies in all these animals and their laboratory studies. So you have their precise laboratory conditions and their administered mycotoxins and then specific binders and see what happens. But there's no medical or scientific published studies to support their use in humans. So how to go about helping a person diagnose. So assuming the person has had the usual tests, serum chemistry, CBC, urinalysis. What do you need? You also need a vitamin D3 level. It's surprising, but out of 100 patients that I'll see, many of them, the great majority, talking about 80 to 90% have low vitamin D3 levels, below 30 or 40. I like to see D3 levels between 50 and 80. So I give them vitamin D. I recommend they take vitamin D3. Mycotoxin antibodies to 12 different mycotoxins, and you want both the IgG, which is the toxic part, and the IgE, which is the mast cell stimulation part. And then I also get levels of the person's immunoglobulins, their serum, the patient's IgA, IgE, IgM, and IgG levels. And you also should get with IgG the 4 subclasses, because IgG is the only one that has 4 subclasses. So the total might be normal, total IgG, but in the subclasses, there might be some deficiencies, and they're made up by one of the other subclasses being too high. So here's the 12 mycotoxins. And they've all been extensively written about in the medical literature as to their effects in humans. Like I mentioned before, they first affect the brain, then the lungs, and they cause intestinal permeability. There's a lot of stuff on the internet that they do this and that to the liver, and you've got to use the binders and all this kind of, there's no evidence of that. So again, base what you do on evidence, on solid evidence, not on somebody may put on their website or even say at a conference. If they say at the conference, just the question and answer period, please just go up to the microphone and say, can you please share with us any studies that support what you say? I've done that. They didn't like it very much, but that's okay. So it's been known, and this is 30 years, that antibodies for mycotoxins are the best way to test. And so this just tells you that and there's tons of studies out there to support this. Treatment. This slide is probably the most important one in treatment. You have to apply the first rule of toxicology, which is get the patient away from the toxin or the toxin away from the patient. And then second, you've got to build back up the immune system and give an antifungal, because remember, these mycotoxins come from the spores. And if you've got spores living in the nasal passages and nasal sinuses, and you've got them living in the lungs, et cetera, well, my gosh, you've got a problem. And then, you know, these patients feel horrible. Why? Because, of course, we discussed how mycotoxins, the first place they affect is the brain. So they're very fatigued, very tired. There's a lot of inflammation. So that inflammation translates in pain, as we all know. And that inflammation extends to muscles and joints, aches and pains. They don't sleep well. They've got short-term memory loss. They can develop anxiety and depression. And many of these mycotoxins just go right through the blood-brain barrier. So they don't have any problems getting into the brain. So itraconazole is what I've used for a long time. It really works well. Some people get very nervous. Oh, what about the liver? Well, you know, after 14,000 patients, I've had one patient with an adverse reaction. This was a 43-year-old female, a lady, who developed total insomnia. And I had no idea that itraconazole, Sporanox, can cause insomnia. So I looked it up, and sure enough, in the potential side effects, which literally are hundreds and hundreds of various things, there I found that, yes, it can cause insomnia. So I took her off, and she slept like a baby thereafter. Melatonin is a great neuroprotector. This has been written extensively and studied extensively at the University of Texas, San Antonio. As I mentioned before, make sure you give them vitamin D3, C, vitamin C, and B complex. If any of you have read any of the books by Dr. Tom Levy, he's an MD and a JD, he's a lawyer as well, but he's a cardiologist. He wrote a tremendous amount on vitamin C and how it reduces reactive oxygen species. It does all kinds of things, and we don't use it hardly enough. B complex, there was a study done at the University of Manchester in England, where they have a very good soccer team. And they took two groups of pre-Alzheimer people, and they all of them had a neuropsychological evaluation. All of them had an MRI of the brain, and they gave half of them, they told, please follow your doctor's directions. And the other half, they said, please follow your doctor's directions and take this high dose B complex vitamin. After 1 year, they repeated the MRI of the brain, and they repeated the neuropsych evaluation. And lo and behold, it was wonderful. There was such a difference that that they published a study, and I've been recommending B complex ever since. Glutathione in some patients, and I use that in patients who've had liver issues. What do I mean by liver issues? One time or another, they had in their use, say, vitamin, they developed hepatitis A, or at one time in their life, they were heavy drinkers or something like that. Then I use glutathione. Otherwise, I don't use it. Magnesium. Magnesium, if you take magnesium, it peaks in your blood in about 2 hours. And then 2 hours later, it's gone. You've excreted it. And I published an article on this several years ago. So the best type to use is a long-acting magnesium. Phosphatidylserine, not the choline. Phosphatidylserine is great for the brain. It does all kinds of great things. So then diet. So let's talk about this, because 80% of the immune system, 70 to 80% of the immune system is in the gut. And if you've got someone with an abnormal immune system that's starting to go autoimmune, this is what the first place to begin. You give them probiotics. The question is, which probiotics? So Dr. Simon Cutting at Reading University in London, by the way, if you ever go over there, go to the Reading University. It's beautiful campus, absolutely gorgeous. He did studies on the main probiotics, which are basically lactobacilli and bifidobacteria. And lo and behold, what he found was that over 90% of lactobacilli and bifidobacterium die in the stomach. Why? Because of gastric acidity. Remember, gastric acidity is part of our innate immune system. You've seen little kids, babies, crawl all over the floor and stick everything they can in their mouth that's been lying on the floor, that's been sniffed or chewed by a dog or cat, etc. And they don't get sick. Why? Because we have this gastric acid that's wonderful that destroys bacteria. So what probiotic do you use? Well, what you use, what he found out, Dr. Cutting found out, Simon Cutting, is that spore-forming bacilli work. They go right through, they're not affected. And don't forget, after the stomach comes the bile acids. They're not affected by that, and they go and they're true probiotics. If you remember, I don't know if you know this or not, but Dr. Eli Mechnikov was the first one who found out about probiotics. And he's the first one who coined the term, which means for life, pro-life. He went to this, rumors were around that there's this place in Bulgaria where people were living really for a long time. They were blessed with long life. So he went up there and found a town where he started studying them and what did they do that they lived so long. Eventually he found out that they used yogurt. And that's even today in all Latin America, it's known as Bulgarian milk, leche bulgar. So we know that probiotics really help, and it has to be the best to use is spore-forming bacilli. And then let me take you here, because a lot of doctors, what happens is that Candida, which is a yeast, you can use fluconazole for yeast, but remember, yeasts are different than molds, and fluconazole prevents candidiasis, has no effectivity against molds, none. Okay, and remember that everybody's immune system is unique and different, like a fingerprint. There's no standard treatment. It has to be individualized. There's no one size fits all. There's no protocol, and these protocols are so popular on the internet. You know, so can you imagine a 20-year-old female that weighs 105 pounds gets the same treatment as a 55-year-old male who weighs 220 pounds? That doesn't work in treating patients. So make sure that you base your treatment on medical and scientific evidence, not on all these things that are said and written about and talked about on the internet. I found this as a very helpful tool over the last 30 years. I call it an immune function questionnaire. And here's it's my total one that I give to all new patients is 14 pages long. It goes through their whole life. This is the first 2 pages, and on the left side, it's the severity of the symptom, and on the right side, when did you first notice the symptom? So on the left side, you get how severe it is. On the right side, you get when did it first start? And then here's the second page. So I see patients every month to every 6 weeks for follow-up, and I just use this because they themselves are telling you, and some of them forget how bad they felt. So this is a great tool to use. When a mold is a concern, So water damage from leaks and any musty odor, chronic condensation, and standing water in the AC unit and in humidifiers. I tell my patients, don't get a humidifier. Carpet conditions, especially how old they are or if they've had water damage. The drapes, upholstery, ceiling tiles, books. Go to places and look at the ceiling tiles and you can tell right away if they've had a water intrusion. And remember, indoor plants can have mold growth on the dirt and on the pottery. So what do? And I want to say this today, it's obvious, but today every house has several bathrooms, has maybe an ice maker, has a washer and dryer, has a dishwasher. All these can have leaks. Okay, so it's not an obvious leak like a roof leak, and then all this water comes in every time it rains and drips. No, it can be behind the refrigerator where you've hooked the line, or the person has hooked the line into your refrigerator so it spits out cold water and ice. So you've got to look at that. You got to maintain a low indoor humidity, below 60%. The ideal is between 10 and 50. And remove all the mold damaged, water damaged materials, including drywall, etc., as well as furniture, carpets, drapes. Think of bedrooms, you're looking at mattresses, sheets, pillowcases, etc. And lastly, I mean, here's all the references. I've got 4 or 5 pages of it, and I can send you more. Let me give you my email address. It's A. Campbell, or let me give you a better one that's easier to remember. Immune Doctor, and the doctor is spelled out. immunedoctor@gmail.com. So email me there. I'll send you the form, information, etc. The lab for mycotoxins is mymycolab.com. The lab for Lyme is Immunosciences Lab. And the best lab for autoimmune panels of all kinds is Cyrex Lab, C-Y-R-E-X. So Myco Lab, Immunosciences, Cyrex. Any questions?
Any use for low-dose naltrexone in the when we have the interleukin-6 involvement?
I'm sorry, I didn't understand your question.
So we've had several lectures on low-dose naltrexone over the past several weeks, and there seems to be quite a crossover with interleukin-6, and low-dose naltrexone seems to be quite effective against it.
That's correct.
Have you used that?
That can be. That can help. Again, you remember I said that you've got to use your judgment of the patient, because some patients will really do good on it. Other people may not do as well.
Right. Okay. So. Okay.
And by the way, all these labs that I just mentioned, they don't accept insurance. They're all fee for service.
Yeah, most of us are also. Yeah, we like it that way, actually.
Yes, we do, don't we? My father told me that whoever pays you, sends you a check, you work for them. I don't want to work for United Healthcare or Blue Cross Blue Shield or Aetna. I want to work for my patients. Amen.
Okay, I have a question here to put the information on the labs in the chat here. So I'm going to put it in here as best I understand it. If you get a chance, Dr. Campbell, can you just check it to make sure I got it right?
Yeah, mymycolab.com. My microlab, this is an oddity because now, have you ever heard of Lapland in Finland? They have this real interesting uniform, and they do reindeers. Well, Finland has the highest rate of dementia in the world. And if any of you have listened to some of the lectures and read some of the studies made by a doctor that specializes in nothing else but Alzheimer, Dr. Dale Bredesen, he showed a study that where they did autopsies on the brain of patients who had Alzheimer, and 28% of them had mycotoxins in the brain. Now, I can tell you, I've treated a number of patients who came to see me because of Alzheimer, usually with their spouse. And I can also tell you that Cyrex Laboratories has a test for Alzheimer's. They call it a LINX test, L-I-N-X. So when they come to me, the first thing that I do is a LINX test. And if that shows very few things or none at all, I do the mycotoxin test, and it's positive. The other thing is, several studies have showed that if you do the mycotoxin test and it's positive, do an autoimmune panel after that. Or if you have an autoimmune panel and it's positive, do a mycotoxin antibody test.
Okay, anybody else have any other questions?
Dr. Campbell, great talk. Don't know why. Hello, is that better? Dr. Campbell, great talk. Just wondering about your thoughts on there being a gene or genetic that we should check to cinch the diagnosis of mold.
You mean like the HLA test?
Yes. I heard a lecture, and they described that if you have all these symptoms and you do a genetic panel like the HLA, that you would be able to just nail it, the diagnosis.
Well, a lot of Shoemaker followers do the HLA-DR test. And I looked it up on PubMed, and you can too. There's only one study on HLA-DR that relates to anything to do with molds or mycotoxins. And that is for a disease known as APBA, which is allergic bronchopulmonary aspergillosis, which is usually a disease that cystic fibrosis patients develop. And by the time they have, during a severe episode, they're usually hospitalized in the ICU because they need help breathing. And they may have a positive HLA-DR. Now, Shoemaker and his followers say that 25% of the American population has a positive HLA-DR, and that means that their immune system isn't functioning properly. 25% of the American population, of the population in the United States, is about 82 million people. Yet there isn't a single medical school, medical journal article. There isn't the NIH has not funded anything to do with that. It's basically not known, except with Shoemaker and his followers. So I will tell you about another disease that affects 32 million, 50 million people less than the HLA-DR test, okay? 50 million less, only 32 million. But it's taught everywhere. Everybody's heard about it. Everybody knows it. It's called diabetes. So if diabetes, which affects 32 million Americans, is so well known, how come no one knows about this HLA-DR? So again, I'm an evidence-based physician. I look at medical and scientific evidence before I'm going to recommend my patients to spend their money on any test that has no backing, nothing, no one knows about it except for a handful of people.
Makes sense. Understood. Thank you.
You're very welcome.
I have a question on drug interactions with itraconazole.
Yes. So any drug interactions with itraconazole, how long do you treat?
Right.
Basically, I treat my patients if you really treat your patient, and most patients get well within 6 to sometimes 8 months. Okay. Why?
Mm-hmm.
Because if you're into microbiology and they've got a virus or this or that or the other, or bacteria, you give them a pill for that. But in toxicology, like mycotoxins, mercury, pesticides, arsenic, it takes a long time to get that stuff out of the body, to treat the body, and to get the immune system strong enough to fight it off and get rid of it. So that's why it takes that long. 6 months is the average for me, and has been. And I use the itraconazole during that time. Now, as far as drug interactions, there's a few drugs, but like I see many patients who are diabetics or have hypertension or both, or have other chronic comorbidities. Never a problem. However, but on the other hand, I always do a drug interaction screen on new patients when they come in and they're taking a whole bunch of medications. And I show them the drug interaction screen so they can see that all these other doctors are giving them medication that fight each other or make one be higher or lesser than the other one. So, but I haven't had any problems with drug interactions, but I always look it up.
Okay. And what about common side effects or patients who can't tolerate it? What would be a usual scenario there?
I mean, or
nothing. If it's not, then it's not.
Yeah. So honestly, I haven't had anyone who can't tolerate it. But I know it's possible. So if they can't tolerate it, I would switch to voriconazole.
Okay.
But the issue with voriconazole, it comes with a lot of side effects. I tried it. I mean, when Pfizer first came out with it back in about 2005, 6, 7, somewhere in there, I tried it. And they, the drug rep left me a bunch of samples.
Okay. Now there's Dr. Gerber has a hand up. I don't know exactly what that means, but if you're there, you can let us know. I don't know what that means exactly, but so we're learning how to use this thing. So, okay. Anybody else have any other questions, comments?
I have a quick question. Do you find that you get good nasal penetration with the itraconazole?
Yes. However, I will tell you that in the study that I mentioned in this lecture about Dr. Ponikow and his study, he added itraconazole amphotericin B nasal spray. And sometimes in some patients who have a lot of colonization in the nasal passages, you need to add the amphotericin B 0.3% solution.
Okay.
Following that question, the ENT that you mentioned that had done all that study as far as looking in the sinuses, is it something that can be visually detected, or is it something that only can be picked up through culture?
You can try the culture, but it's usually very hard to get deep enough into those sinuses. Because remember, we're talking about mold spores being 2 to 3 microns thick. They go way up. How are you going to get them out of the frontal sinuses? Very difficult unless they're anesthetized.
Right, I understand that, but you were saying that he had done, I thought you said he had done some sinus surgeries, and I wasn't sure if he had gotten cultures and that's how he knew it was mold,
Yes.
or how did he know it was mold?
Well, what he got is whatever, he got this stuff out of their nasal passages and sent it to lab to identify, and he told them, do whatever you need to do. So I'm sure the lab did all kinds of cultures.
Okay, but it wasn't visible to the naked eye.
And you can read the study. It's a very interesting study. And the lab, I don't remember exactly what that part said about what all the things are. I just remember that 96% of what Ponakow sent them from the OR was mold.
All right, thank you. Because I had referred somebody to an ENT in regards to this, and they said they looked at their sinus and it looked completely fine and they saw no signs of mold. But I didn't think it was something that was actually going to be visible. I thought it was something that probably would require a culture.
Remember, to culture bacteria is much easier because fungi, you've got to culture for 21 days, and it's a different medium for culturing fungi or molds.
Question about, I'm sorry, go ahead, finish.
That's okay. One follow-up question. You mentioned that you don't use binders. Do you ever find that there's a die-off, almost like a Herxheimer reaction, and that the binder can be helpful for that?
Again, show me a study that shows that. One study. I don't want more than one. If you can show me one study that says, we tried this and found such and such about Herxheimer reducing, the binders reduce Herxheimer, I'll be happy to read it and et cetera, and start telling people about it. But what I've seen with Herxheimer, in my experience with these patients, is that it's a very, very small percent that get a Herxheimer. And usually I tell them, look, stick through it. It's only, you're not going to feel kind of fluish for 3 or 4 days, and then you'll be fine. And if you read Dr. Yarish and Dr. Herxheimer's paper, and unfortunately, I was educated and I grew up in Switzerland, so German is easy for me to read, and their studies in German. But if you can get it, you can find a translation, it's very interesting what they found. And they were dermatologists. These two guys were dermatologists. Of course, everybody says Herxheimer, and they leave out the other guy, Yarish. He should be part of the credit.
Okay, we have vitamin D dose and vitamin C dose. I know vitamin D, you like to get the blood levels to 50 to 80.
Right, 5,000. I use Claire Labs. They've got a good vitamin D product, and it's 5,000 international units in a capsule. Take it one a day. And by the way, I'm on various restricted email groups by invitation only kind of things, mostly from people who have published and who are on faculties. And this one doctor gave huge doses of vitamin D3 for a patient who had COVID. And he saw some remarkable results, because don't forget, vitamin D3 really affects the immune system. It's more than just a vitamin. The other one about vitamin C, I try to give 3 grams 3 times daily. The thing about vitamin C is if it goes beyond your tolerance, it's your GI tolerance. There is no overdose. There's no dose that you can overdose on in vitamin C, by the way. There's no overdose. But what you need to do is give about 3 grams 3 times a day. Now, if the patient says, I developed diarrhea, knock it down 1 gram. So 2 grams 3 times a day. And see if they tolerate that.
Any particular brand there?
I use, again, I use Clear Labs.
Okay.
I use Clear Labs, 3 milligrams of their melatonin, and I give that at HS at bedtime. Again, although it helps their sleep, remember, it also is a protector.
Correct. Question, source for phosphatidylserine.
Clear Labs is where I get it.
Okay, seems to be a theme here. So
yeah,
good.
The
good.
magnesium I get from, it's called Jigsaw Health, and it's their Mag SRT, Mag for magnesium SRT sustained release treatment. And that's what I use with them, Jigsaw Health. And then I use for these spore forming bacteria. It's called Megaspore Biotic.
Right.
And it's made by Microbiome Labs.
Right.
I also give these folks Omega. It's a combination. It's Dr. Steve Sinatra. I don't know if you know him. I've known him for a while, but he has a product called Omega Q Plus Max. And what it is, it's omegas, it's coenzyme Q10, resveratrol, and it's curcumin, all in the same capsule, which is great for patients because they get 4 things in one capsule rather than 4 different capsules. So I personally take it every day. I take 2 every morning. And I tell patients that it will help them too.
Could you repeat that one? Just
sure. It's I'll type it in.
Okay. Steve says it sounds like a horse pill. So. Okay, great. Okay. I know you touched on it briefly, but at the beginning you mentioned about mast cells and mast cell activation. Any particular dietary tips?
Yes. And mast cells, I mean, diet is very important in all of this, especially in the part of mastocytosis. You've got to get no alcohol. I mean, not even rum cake or something like that. That's one. And you've got to put them on a low histamine diet.
Do you have any particular diagnostic tip for that? I know there's a tryptase enzyme, but that's kind of tricky to work with.
What we did in this study is one of the GI folks at Washington U, what he did is he did the Mycotoxin test, and he found that his patients who had MCAS, the study was on MCAS, mast cell activation syndrome. So what he found is they all had elevated mycotoxin levels, number one. Number two, when he asked them if there were any leaks, et cetera, they all said, yes, there are. And then that's his first step was to go first stuff that he did was, of course, put them on the diet, get them out, or have the area remediated where they had the mold, and got well. There's a question here about gluten. I usually tell patients 90 days gluten-free to start off with, and I'll see how they do.
And just in my own experience, I tell them it's a Judge Judy deal. It's a yes or a no, not a little bit, not a, just a, either you're going to do it or you're not. So
yeah.
So okay.
And LDN, low-dose naltrexone, helps some of these folks, but some don't. And it's hard to tell which ones are going to be helped and which ones not. So, sometimes you got to try something.
Right. So, yeah, we've had a lot of good success with that in a lot of different areas. It's inexpensive. The side effects.
Patel. Is this the same Patel who knew Dr. Bill Ray? I wonder. Anyway, Dr. Patel usually is asking how long you treat with itraconazole. 6 months. Now, when I first started using itraconazole, I checked liver function tests every 2 weeks. And after many, many patients with no changes, I switched to checking their liver function test every 30 days. Nothing showed up. So I check it every 6 weeks just out of precaution. I still have not had a single issue with that.
This is Dr. Patel. And I was just wondering that what biomarker would you use that this is enough treatment besides the clinical evidence of patient getting better?
I'm hearing some background noise.
I have no idea who the hell you are. I have always been consistent on.
You hear that?
I hear a TV. Yeah. Well, that's him.
Excuse me.
All right, that was Dr. Patel's.
Okay, so can you repeat or type it in the chat?
Let me find her.
I think she was asking, other than symptoms taken, what specific biomarkers would you look for?
People like to do blood tests, and so many of them are non-specific. C3A. What does that marker tell you? There's some inflammation somewhere. Well, what are you going to do? How is that going to affect your treatment plan? It's probably not. So, I don't treat lab tests. I treat patients. And if they come up with a new symptom or something's happening, then I'll focus on that and help them through that. But I don't order a lab test for every symptom. I do, I want to make sure they have serum chemistries. I want to make sure they have a CBC with differential, a urinalysis, and then I do the mycotoxin, mycolab test. If it's positive, I order an autoimmune panel.
Yeah, can we say, this is Dr. Halasa, can we say that the fungus or mycotoxic is more of a factor, but not the absolute cause? And
sounds like we lost them.
Okay, can you hear me, guys?
Yeah, we hear you now.
Okay, so you can have two people exposed to the same fungus, and one has the symptoms, another doesn't. So there's some genetic background there. And we can say that environmental toxins is triggering those genetic, but it's not an absolute factor. We can say it is a trigger factor, but must be some genetic background. Those patients with psoriasis, and you help them, yes, but they have some genetic factor of having psoriasis. But the fungus is a trigger it. And yes, if you remove the trigger, it definitely healed, but does not mean that genetically they are healed. So they still have the psoriasis as genetic background. Can we agree on that?
Okay, so let me address those two. Number one, it's not the fungus that does anything. Fungus is a live organism. We're talking about a toxin, and toxins act differently than live organisms. Second, I'm the editor-in-chief of 2 peer-reviewed journals. I scour the medical literature like you wouldn't believe every day. I get articles, submissions from all over. I also review everything because I'm a speaker at many, many conferences, and I'm doing studies with other university medical centers. So if you tell me that there's, that it's this and this, and it's the genetic marker, et cetera, well, here we showed that ALS, the genetic part is only 5 to 10%. The 90 other percent is environmental. That's a major disorder. I mean, it's in most people fatal unless you catch it early and remove the environmental factor. If they have the genetic, that's it. It's the same if you read Dr. Dale Bredesen's book, The End of Alzheimer. Yes, there's a genetic component, and there's not much you can do about that, but all the rest you can change and affect the person's life. And if you've been to some of his conferences, it's really impressive because he shows people who look like they're obviously demented. And then he shows the same person 6 months later, and they're lively, and they're talking, and they're laughing and chuckling and having a great conversation. So yes, there's always the possibility of a genetic, but it's not like it's major. Number one is the genetic, and then everything else follows afterwards. It's the other way around. And and hopefully somebody will clarify that with some more studies, but that's what the medical literature says.
Yeah, but the idea of top 5% of ALS is genetic and the rest are not genetic, sporadic. Sporadic does not mean that they're not genetic. They don't know what it is. Could be genetic, could be environmental. So they don't know, they put it sporadic. So that's just to clarify that point. Can you hear me, guys?
We hear you.
Yeah, so that's one point. The other point, yes, I'm talking about the toxins, and you're right, whether it's fungus or toxins of it. But again, you know, I'm just saying it does not undermine that elimination of the toxins. It's part of the management, of course, and you can have patient-free symptoms, but there must be some genetic background in addition, because you can have both people exposed to the same thing. One has a problem, the other one doesn't. And yes, if you remove the toxins and all that, that will be completely normalized. But that does not mean that there's no genetic background. That's my question here.
Again, if you can point me to any publication that supports that, I'd be happy to review it and take a, and see what it says. But I haven't seen anything to that effect.
Okay, anybody else have any other questions, comments? Any final thoughts, Dr. Campbell? Summary, marching orders?
Go forth and multiply.
Was that the Star Trek, or was that the some other book?
No, I mean, if you see all the studies that I look at, the World Health Organization calls mycotoxins the great masquerader. Why? Because it masquerades as chronic fatigue syndrome, Lyme disease, fibromyalgia, all these other things. I treated a young man, 28 years old, who was diagnosed by 3 different neurologists as having MS when he was 22. And he came to see me because his sister told him to come and see me. And he was dragging his foot, and he would be fatigued after he walked like 30 feet, 40 feet. He'd be totally wiped out. And he, you know, his neurologist was following him every 6 months. And I saw him, and I did the antibodies for mycotoxins on him, and he had a whole bunch. Now that was in September, 1 year ago. And he couldn't work because of his fatigue and his limitation in movement, et cetera. I treated him for mycotoxins, and he got better. And then in May, he started playing volleyball. He would have never thought he could play volleyball again. And then he saw his neurologist for his twice-a-year examination. The neurologist did the usual stuff with spinal taps and et cetera, and couldn't find anything. Of course, I've got to write this one up because it's as a case report. And I'm going to be doing that in the Journal of Immunology. But, you know, I've done this for 30 years and I've seen all kinds of stuff like that. I'm treating several docs with ALS. So it's a great masquerader.
One question here, and it would have to be an approximation. The percentage of patients that you test will be positive for mycotoxins. Obviously, you're seeing a skewed population to begin with. And you have to have a suspicion that it's there before you even do the test, right? You just don't do it on everybody who walks in the door.
Well,
or do you?
There's a bunch of studies that looked at patients with known exposures and patients without known exposures, comparative studies, et cetera. And I've been a co-author on several of those. So if you go to PubMed.gov and type in and A.W. Campbell, Andrew William Campbell, you find those studies. But, you know, it's not like I do a mycotoxin test on everybody that walks in the door.
Right.
You know, so I see patients with all kinds of disorders and diseases.
So what percentage, can you give us you know, an approximate percentage of which those patients end up with, you know, they determine those are the mycotoxin ones? Well,
I use the tool that I told you about,
right,
the immune questionnaire, and that helps me. Some of these people I don't even do a test on, because usually they've been to see other docs, and then they come up with me and they bring all their files and all their imaging, this and that and the other and whatnot. And, you know, I may not even do any kind of a test for them. Here's an article that's being sent. Let's see what this one is. How much should we involve?
Can you click on that?
Factors. Okay, this is a study that, the study is how much should we involve genetic and environmental factors in the risk assessment of human mycotoxins. This is in the International Journal of Environmental Research and Public Health from 2005. And this is basically from French University, the University in Bordeaux. And they looked at 21 persons who were exposed to ochratoxin in a diet. So this is not from anyone who was exposed from an indoor environment. That's the first thing that would make a difference.
Mhm.
Mycotoxin, by the way, just so you understand, in a study that was published several years after this one, cannot be, mycotoxin cannot be excreted in urine because it's 99.6% bound to albumin, the #1 protein of the body. So it's reabsorbed from all parts of the kidneys. And it's the only mycotoxin that goes to that can be excreted as well. So I would say that this is a study based on diet, but it's not based on other factors. So most of the studies that I've mentioned, well, all the studies that I've mentioned, none of them are dietary. All of them are from a water-damaged environment where mold growth started.
Mm-hmm. Like on a roof. I got a roof like that as we speak, so we better get on it, huh?
If mycotoxin can't be excreted in the urine, what does it mean if it appears on urine testing? Well, if you call the urine testing labs and ask them for evidence of their lab methodology, they can't give it to you. Second, go to Google and Google urine test for mycotoxins. And halfway down on the first page is a statement by the CDC saying that these are not validated tests and should not be used for medical diagnostic purposes. And this is one of them.
Just let me make sure that I really appreciate, and I know your presentation was, I like it so much. Your presentation is great, and I am very pleased and to say that. I mean, your presentation was the greatest of the great. I like everything you do. We need a lot of those information. So just to make sure that, you know, my point is not to saying, you know, you're wrong or right. It's just more or less adding if we can add. And I'm not here to challenge. I'm just, you know, in general speaking, and hopefully in a humble way, that if we just make all the diseases as it's mycotoxic, that would be great. I mean, we can just go ahead and manage the mycotoxic and everybody will be cured, including ALS. And I like that will be the case, and hopefully that will be the case. And looking forward to hear from you. But I really appreciate your presentation. It's just it's one of the greatest presentation I have here. And I would like even to have your name and present at my conferences. We have the weekly webinar on Monday. So I'm going to steal you from Dr. William Bill. But your presentation was great. So, and I just want to say that, you know, it would be good if we just add the genetic thing, because if those patients are not being, you know, completely cured, or in other words, they have remission, they must a little bit of genetic background. That's what I'm just saying. But of course, I think we need to focus on mycotoxins, and we need to clear that. Because this is something can be reversed. Other than that, it's just difficult if you have a genetic makeup as being corrupted. But thank you very much for your presentation.
I think, and I appreciate what you said. I can tell you that there is a person who is funding a study with my Mycolab and another lab that does genetic testing for the purpose of exactly what you say. We know a lot more now about just about anything in medicine than we did 5 years ago, or 10 years ago, or 20 years ago. And now people are starting to get interested in the genetic component, if there is one, and if so, what is it and how is it? Is it in the part that regulates molecular interaction in our genes, that some people may lack a gene for this or for that? One interesting fellow who does this is Bob Miller. and he has a saliva test, and he's got a great, lab, I think, in my opinion, for checking for things. And a lot of people are doing that test, that genetic testing, and my MycoLab testing. A lot of practitioners are doing the two tests, and we're going to start trying to gather the data to see if there is or what kind of connection there is. Because, for instance, there's some people who, if you give them glutathione, do terrible. They get sick. Well, why? Why can others take it and others not? It's supposed to be something that we have naturally in our body. So yeah, there's a lot of interesting factors. We're still finding all kinds of interesting things out.
Okay. Yep. Anybody else? Any questions, comments? Steve stated that he's learned a lot tonight. I think we all have. Dr. Campbell, we can't thank you enough for your time and your effort. We like, if it's okay with you, we like to putting the recording on our website for others in the future, if that's okay with you. And Dr. Campbell's going to be presenting at our conference in Las Vegas. I think I have you on Saturday. I don't know if I gave you the exact time, but I'll send that to you later tonight or tomorrow. And we also have, you mentioned Dr. Levy, and Dr. Levy's coming too. So we have him too. And we have a couple of other special guests too. So I think this is, you don't know this is actually our 50th anniversary for the American Osteopathic Society of Rheumatic Diseases, and it's the 4th for the Integrative Health Alliance. I think it's going to be our best show ever. We really hope that it will be online, but we would love to have you all come in person. We always have, little fun things we do and surprises. Those of you who've been to our shows in the past, I got to do it from my kitchen table last year, but we've had all sorts of really interesting. We are the cutting edge in the AOA. They don't really know what to do with us, it's really we're really the integrative medical society within the AOA. Those of you that are new, please, if I don't have your contact information, please get it to me. We do have a couple of openings left still. If somebody wants to present anything, let me know. We focus on rheumatology, autoimmune issues, of course, hormone issues. We have a cannabis section. We do practice management. We do the state required lectures that are pain management, suicide prevention, and I think this year we're going to be doing an ethics lecture also. So those 4. So anybody who has state requirements, those are usually the ones we cover all of those. And we're at the beginning of the year, so you'll be able to get that out of the way. We're also looking into having a breakout room where we can do some special workshops also. So if you're interested in presenting something more than a 45-minute to an hour a topic, let me know about that. We have several ideas in the works. Dr. Campbell, again, we can't thank you enough. I look forward to your participating with us again in the future. If there's anything any of us can do, please let us know. If you have any conferences, anything that you need publicized, please let me know. We will get it out to our members. We have over 1,800 contacts that go out every week, and so we have quite a broad range. You've put your email address in there, immunedoctor@gmail.com, and we have we'll have this up within 72 hours. And the video at aosrd.org/webinars. aosrd.org/webinars. Dr. Burgess, you have anything to add? You still there?
Yeah, I'm still here, and it was a wonderful lecture, and everything's good. Thank you, Dr. Campbell.
You're very welcome, everybody.
Thank you
Thank
so
you
much
for having me and listening to me talking for all this time.
Okay, no, it was a pleasure. Thank you so much, sir. And we'll be speaking in the future. Okay, everybody. Next week we have Dr. Zarin, our resident homeopath. She's going to be enlightening us. You know, there's always a COVID theme, which, quite frankly, I'm kind of sick of. But so she's going to be enlightening us on her latest homeopathic remedies. And then on December 28th, we have we're going to let me go look it up. So December 28th, we have Dr. This is what happens. My Alzheimer's is kicking in. We have pairing nutrition with regenerative therapy with Dr. Hobbs, who is also quite an interesting fellow. So anybody have any questions, comments, complaints? Dr. O'Neill Smith, thank you for being here. The people that are new, that are the names that I don't recognize, Dr. Alvino, and Dr. Mikuluk, I think you've been here a few times, and there have been a few others. There's a few other new names here. Dr. Steenbach, we've been trying to get in touch with you for about 3 years now, so don't be a stranger. Not sure how you got to us, but thank you for hooking on here at the end. And we have our conference coming up at the end of March rather, in Las Vegas, and we still have a couple of openings, and we're looking for our integrative community. We are just a couple other things in case you're interested. February 12th, we're being reevaluated for our accreditation. I think everything is in line, Dr. Spear, and I'd be surprised if we don't get the maximum. I would really be shocked. We should get. I think the maximum is a 5-year accreditation, and I don't see any issues with it. We have everything is in order, that's it, everybody. I'm done. Anybody else have any questions? Thank you for coming. The regulars, thank you for being here, and the new folks, thank you for being here. And Dr. Steenbach, if you could leave us contact information, that would be great. Dr. Alvino also would be great. And if not, we will be here. Same link, same time, same station next week.
Thanks, Bill.
Thank you.
I know you were never going to get on a bull, but how about taking those nice long walks again, or gardening? I was skeptical that anything that's 100% drug-free